next. So at the risk of being biased, I'm going to introduce one of my own PhD students. But Katy is just finishing off her PhD working in Sierra Leone, and she has specifically been looking at a number of things related to preeclampsia, but what she's going to share with us today is some of her work around the point of care angiogenic markers, which has been a prerequisite for us for moving forward about how we're going to use them in the future. Katy, thank you.
Thanks, Andy. I'm just getting my slides to the beginning. Oh, I hope I am. Hang on one second. Okay, can everyone see my slides? Is that okay?
Katy, looking good. Yeah, no.
Okay, great.
You haven't actually got them on full screen because we can see your slide that's coming.
Oh, okay.
I don't know if it's a simple button to sort that out.
It's on presenter mode at the moment. It's now on main mode. We don't see your presentation slide.
Slideshow there. I thought there was a way I could present it, but also look at my notes, but I can just do it without the notes.
You should be able to if you.
So presenter view. So you can still see my notes here, can you?
Yes.
Yeah.
Yeah.
That's it. That's it.
Okay, fine. Right. Hello, everyone. Thank you for the introduction, Andy. I'm also in Sierra Leone, so hopefully my Wi-Fi will also hold out. I'm going to talk to you about evaluating a novel point-of-care PLGF test. This is part of a larger NIHR-funded global health group focused on simple interventions to improve maternal mortality. So, as everyone here knows, obviously, hypertensive disorders account for nearly a quarter of maternal deaths globally, and this number on this slide is reflective of our Sierra Leone data, where hypertensive disorders and preeclampsia are the second leading cause of maternal death. A key reason for that being delayed detection, leading to delayed management. And so the premise behind using point of care testing, I'm looking at a number of different point of care tests as part of my PhD, but obviously I'll be focusing PLGF here. But the point of that is if a woman is struggling to access early detection so that she can get the management she needs due to challenging laboratory infrastructure, etc., then take the test to her. These are the other studies I'm looking at, but today I'll be looking at point-of-care PLGF in early preeclampsia prediction. So this slide is not to talk about the pathophysiology of preeclampsia, because I know you're all well versed in that, but just to emphasize the fact that there are different ways that preeclampsia can present, and it's also obviously rapidly progressive in some circumstances. So it's not only difficult to diagnose, but important, because obviously timing of delivery is essential to ensure a better outcome for the mother and the baby. And women in Sierra Leone are 2,000 times more likely to die from preeclampsia than a woman in the UK, even though interventions are available. So placental growth factor development. Placental growth factor, as you all know, has been shown in the UK to halve time to diagnosis and to decrease maternal complications compared to usual care, and also to save substantial amounts of money, and has been introduced into NHS care and is recommended as part of NICE guidelines, as well as international guidelines too. It has been evaluated in lower resource settings. So in Mozambique, it was also shown to increase preeclampsia related referrals when it was used, and also to detect stillbirth. But in this setting, it was used as a test which required serum, so centrifuging, and that's not practical or feasible in a setting like Sierra Leone and many other lower resource settings. So the device we're looking at is a simple point of care test where a result is available in 30 minutes. And And our plan was to evaluate this point of care test for prediction of adverse maternal and neonatal outcomes in hypertensive women or women with suspected preeclampsia from 24 to 36, sorry, that should be +6 weeks, presenting to a busy tertiary maternity hospital in Freetown in Sierra Leone. So our outcomes, we kept simple. So the maternal outcome was based on a modified mini-Peers composite, depending on what we were able to collect in the setting, because many of those are resource dependent, and a perinatal composite of one or more of stillbirth, neonatal death before discharge, or termination pre-viability. So this is just to illustrate the ones in orange are the ones that it was more difficult to include and collect because of the dependence on resources, which are very scarce in this setting. So we actually evaluated 2 different point of care devices, both are new. The first one, Ronia PLGF, which requires 20 microliters of whole blood and can be taken as a finger prick sample with the results in 30 minutes. It's micro USB rechargeable. And it's very portable, it's very small. And then the other one was made by a company called Lepsy, and it requires 200 microliters of whole blood and requires a venipuncture sample as a result of that. It has a result available in 10 minutes and can be powered by a battery for a short period of time or can be plugged in. It's also portable and small. So we recruited women and offered them a Ronia or Lepsy PLGF test, which was blinded to the clinicians, so did not inform management. And we then collected the women's study outcomes from their hospital notes. So these are just some pictures of various research assistant trainings, recruitment of patients, and training the Zambia team, who then went on to start an evaluation as well of the 2 PLGF tests. And these are some of the results. So apologies for the busy table, but I'd just like to pick out a few numbers to illustrate the kind of key messages. So first of all, we confirmed that thresholds of less than 20 and less than 60 were the most appropriate to use in the best balance of sensitivity and specificity for both rule in and rule out of adverse outcomes. And for tests done at less than 34 weeks of gestation, abnormal Ronia PLGF we're talking about here had very high sensitivity and negative predictive value for prediction of maternal and neonatal outcomes. So the numbers in green just indicate the rule out, so the sensitivities and MPVs for the maternal composite. Maternal death, where you can see that for tests done at less than 34 weeks, it was 100%, and eclampsia and the adverse neonatal events. So the kind of key message here is that PLGF can accurately rule out adverse maternal and neonatal events. And just to kind of have a look specifically at the adverse outcomes and where which PLGF categories they fall into, you can see just by eyeballing the table that the vast majority of adverse events fall into the abnormal PLGF categories, and specifically the very abnormal PLGF category, which is less than 20. So all but one of the women who died, all but 3 eclamptic cases, and all but 1 stillbirth were correctly identified by abnormal PLGF. And actually the woman who died, we interrogated the notes and found that she was a lady who had multiple other comorbidities, which may have certainly contributed to the cause of death. So moving on to look at Lepsy PLGF, which is the other test we studied. So again, although overall negative predictive values and sensitivities are good for tests done at any gestation, it's particularly good at tests done at less than 34 weeks, where you can see that for all of the outcomes that we looked at, so the maternal composite, maternal death by itself, eclampsia by itself, and adverse neonatal event by itself, there was 100% sensitivity and negative predictive value for ruling out these adverse events. And again, I've presented the data in a similar way. in this table here, where you can see again that the very vast majority of adverse events occur with abnormal PLGF. This is for overall all gestations at testing. So you can see that for all gestations at testing in this table, maternal death was accurately ruled out with 100% sensitivity. So just to also make another point here, when we're looking at these tables of adverse outcomes, and I'll go back to the RONIA one because we had more women in this, in the RONIA, tested with the RONIA test, but you can see that there are 17 maternal deaths, 49 eclamptic cases and 90 stillbirths, which is a horrendous number of adverse events, and comparable to other studies where there's just a handful of stillbirths. We were able to accurately determine the ability of PLGF to predict these outcomes in a way that hasn't been possible previously. So just thinking just about how we would use the results of this test in context, and my reasons for emphasizing the sensitivity at MPV is because this cohort of women is quite different to how we've looked at PLGF in a high income setting, where we can say, oh, well, PLGF is excellent for determining which women have preeclampsia and also when they might deliver. But in this context, we recruited women who had suspected preeclampsia and were already, by definition, a high risk cohort. And actually, it was more important to be able to rule out an adverse outcome. That added more information than ruling in an adverse outcome, because we already knew that these women were high risk in this setting. In terms of how we plan to use it and further evaluate it, so Papagayo is a program of work that we are just beginning at this point in time, and it is going to be looking at when we introduce PLGF into management of women with suspected preeclampsia, can we use it to rule out the risk of having an adverse event, such as the ones we've been looking at in this study. Also added to that, based on our results from Cradle 4, which showed that planned early delivery from 34 weeks reduced stillbirth by 75% and also significantly reduced maternal hypertension. We want to add PLGF into that equation. And so for women from 34 weeks with suspected preeclampsia with a normal PLGF, based on this very good rule out that we've seen in the pineapple study, can we say, okay, well, we won't deliver these women because we can accurately know that she is not going to have an adverse outcome with a normal PLGF result, and vice versa. If she has a abnormal PLGF result, we would go on to deliver her. So in conclusion, this is the first evaluation of a point of care PLGF device with substantial rates of maternal death, eclampsia and stillbirth, and we've confirmed that there is a high predictive test performance for both RONIA and LEPSI tests. The study is also novel, as explained, in the way that we can use it to inform management in high-risk populations in lower resource settings. And this will be further evaluated in the Papagayo programme. So thank you for listening, and I'd be very happy to take any questions if we have time. And this is Moses, one of our research assistants. He's been absolutely key in conducting the research.
Thanks very much. There is time for questions.
Brilliant.
Want to Andy, I think I interrupted you.
No, it's fine. No, do. Actually, I was just going to make the point, I'm sure people will be interested, that we've sort of done the validation work in London, and these tests are pretty comparable to the currently recommended nice, large analyzers like the Delphia and so on. So it won't be long before there's formal kind of recognition that they can be used all over the world, and they're going to be a lot cheaper. So if your goal is just to have an antigenic marker to make a clinical decision, I'm sure we will have point of care, cheaper tests available to us.
So can I come up ask, would this be, at the moment it's point of care testing, so, but it's point of care testing provided by a clinical person, so a midwife or whatever. So the person coming to the clinic, it's a bedside test, which is with immediate results. So is this something potentially would be a user point of care test that the woman can do in her own environment, or from unskilled people within a village or whatever?
So I think definitely I would say unskilled people in a village is a possibility for sure, because of the portability of the device. I think there is a limitation in terms of the fact that it does still need to be charged and requires electricity, which is limited in the more rural settings. But most people can charge their mobile phone, for example. So then by that same thought, you think they'd be able to charge a device. And because it requires, I mean, the Ronia one in particular requires only a finger prick. So much like people can test their own blood sugar, perhaps they could also test their PLGF. I suppose that Papagayo will be looking more at the feasibility of implementation as some of the outcomes. The last trial is an implementation effectiveness trial. So there will be a lot of study of the kind of barriers and facilitators to integrating into routine care in different settings, to answer those questions about the kind of feasibility of its use in resource limited settings, which is where we're hoping to use it.